Okay, welcome, everybody. So, sad day for me. This is my last formal lecture to you guys. I'll be back, well, I'll be in the back of the room every day, but I'll be back up here for the endocrine review session that we have next Tuesday. This is my last lecture of the year, and my wife, Mara, last night said to me, "You giving that obesity talk again tomorrow?" I said, "Yes." She said, "Have you softened it at all?" I said, "No." She said, "Why not?" And I said, "Because the data, which I will show you, is unfortunately just as harrowing as it was when I started to give this lecture about 6 years ago." Dr. Stein came up here and said, if you see somebody with xanthosmas in the supermarket, you might want to tap them on the shoulder and ask them to get their cholesterol checked. So the disease I'm going to talk about today is far more common, and I wouldn't tap anybody on the shoulder and tell them that they may be suffering from this. So I have a feeling you're going to get a not so pleasant response. We're going to delve into two components. I think a lot of people, when I get feedback on this talk, get a little confused as to what the point I'm trying to get across here. What I'm trying to do globally for this talk is make you aware of just how severe and devastating the obesity epidemic is. And we'll talk about some population-based prevalence data on that. And at the end, I'll come back and show you some treatment paradigms for obesity and their unfortunate lack of success. And I'm not trying to be negative about it. I'm actually trying to be thought-provoking, because this disease and what's actually coming 10 or 15 years from now because of this disease is going to fundamentally change just about everything in our healthcare system. It is going to overwhelm it and basically break its somewhat unsustainable capacity as it stands right now. And without some type of intervention for this disease, and we have a few, but they're meager at best, this is going to be a far more severe problem. Many people comprehend that now, but we have a real lack of treatment strategies. And I'm not, again, trying to make everybody despondent when they walk out of here. I'm just trying to be realistic about it. And furthermore, I gave this talk once to a private practice group in New Jersey that invited me to speak, and there was this huge buffet dinner that was going on, and you literally heard, forks and spoons just dropping as I continued to go through my talk. So that is what we're going to talk about today. But, so the second part that I think confuses people is we're going to delve into sort of some basic science aspects of everyday food, appetite, body weight regulation. And it is not a global descriptor. It is very simplified. But it's sort of the going theory that we have, and the players that are involved in it are important in just about every pathway that's been figured out in terms of the pathophysiology of why overweight and obesity are prevalent in our society. So I kind of start with some prevalence and a broad scope, and then we get into very nitty-gritty things that are going on in the central nervous system, hormonally related. And then I sort of come out and bring you to sort of a treatment paradigm. But before we do that, I thought you don't have a small group session devoted to this, so let's walk through a little case, okay? We have a 54-year-old male, presents with a right-sided adrenal mass found by CAT scan. Blood pressure in the office is 148/92. This is normal. He takes no medicines. He reports no prior history of high blood pressure. His potassium on his lab reports from his primary care doctor are all normal. The following would be the appropriate next step in the management of this patient. So there's plasma aldo and renin activity measurement. There's plasma DOAC measurement. There's adrenal vein sampling. There's an intravenous salt load with plasma aldo measurements, and then you should just start antihypertensive therapy. So, show of hands, who favors choice number 1? I need to see them high up. Okay, who favors choice number 2? DOAC is deoxycorticosterone. Who favors choice number 3? Hands up, 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 up. 4. Okay, and 5. Number 5. Okay, so the answer to this question is actually number 1. Okay? This is the style of question we're going to go through for Endorama next week. The reason you don't do this is because of this. Remember yesterday I said hypertension with an adrenal mass begets a workup for endocrine-related hypertension. Okay? So that's a critical part of this story. These can't be done until you've walked down the road of assessing for adrenal hypertension, which you haven't done yet until you get this first. Okay? Now, I can't take questions on this. Okay. Now, I just want you to think about that question and sort of study it, and I added it because you don't have a small group dedicated to endocrine hypertension, but those are the kind of things we would ask you about if we did have a small group. So, this is what we're going to go through today, okay? And I sort of already went through that outline. So, let's just go right to how do we define obesity. So, for adults, we actually use what's called the body mass index. It comes with some flaws. I'll go over a little bit of those. It's an easy-to-do test. All you need is a good, reliable height, so you get a stadiometer, like Dr. Mazumber spoke about in growth and development. For your height, you get a weight. All right, you turn it into kilos and meters squared, divide it, and these are the categories. This category here, greater than 40, it's not really a relevant one. It used to be called class 3 or extreme or super morbid or super obese. They're all terms that don't really have much of a relevance except for treatment strategies. When it comes to treatment strategies for different classes of obesity, that's where your BMI change of 30, 35, or 40 sort of does seem to, at least by guideline recommendations, play a role. But the terminology here is not a very good one, okay? For children, though, it's done a little bit different. It's based on age. It's based on the BMI plotted for age and gender, okay? And it's all based on percentiles. So the 4 categories are underweight, healthy weight, overweight, and obese, and it's overweight and obese that's actually the ones that are, we try and intervene on, at least in the pediatric population. Anybody know what age it's recommended to start checking the BMI for a developing child? Say it out loud. 6? What else? 8? How about 2? Okay. So what are the trends among United States adults? Yes?
If the weight status for children is based on the normal population distribution, how does that account for children getting fatter?
What's that?
The average child in the U.S. has been getting fatter, so how does that still work?
In other words, you're saying what constitutes a normal population? So if you took the entire population as they were getting larger, they'd all be considered normal?
Yeah.
That's not actually the way that they have the normal standardized tables. It's based on what would be considered to be ideal body weight. Okay, so let me tell you a little bit about this survey in case you've never seen this slide before. The CDC called people, landlines, 1990. This is before the days of cell phones, if you could imagine it. Okay? The data is now changed, and they actually use cell phones to contact people, and they changed whether or not you could compare one slide to another. So this is the original data set. Someone is calling you on the telephone and asking you questions about your demographics, like, hey, how tall are you? And hey, how much do you weigh? And it turns out that when you ask somebody how tall they are, well, they lie to you. And they tell you that they're taller than they really are. And if you ask somebody how much they weigh, well, they lie to you then too. And they tell you that they weigh less. So, what does that mean for this? Well, if you're thinking about BMI, that means that this is an underrepresentation of the reality of the situation. And that's been shown when they actually go out into the population and actually measure height and weight, which they've done in other studies. So this is the data in 1990. Now, there are some states that are not reporting any data. And the general prevalence of obesity, okay, this is obesity, not overweight. So BMI greater than 30 is around 10 or 14%. Okay, it is what it is. That's the first year. 7 years later, though, everybody's now reporting, and I should mention, by the way, that I grew up here, and if you go to school in this area, you don't learn a lot about what states constitute these. You barely comprehend this one and this one, and completely are oblivious to these. Like when I was in Illinois and someone told me they were going to Iowa, and I said, "You're going all the way out to Iowa?" And it's right next door. So it turns out that greater than 20% was found in about 3 states, but most states had a less than 1 in 5 prevalence of obesity. Okay, that's 7 years after the first survey was done. Let's flip to 4 years after that. You're now about 10 years after the first survey that was done. And a large swath of the United States population has an obesity rate of at least 1 in 5, if not bordering on 1 in 4. So you're talking about 20 to 25% of the adults are now considered to be obese. In this particular state here, it's at least 25%. By the way, does anybody know what state that is? That's Colorado. Colorado, which used to be one of my favorite states until just a couple days ago, if you follow the news, they have a very aggressive public health campaign and have always had a very aggressive public health campaign to get people moving. They also are higher up than everybody else, and they have a lower oxygen content. Well, people kind of hit upon that idea and said, you know what, if we could suck the oxygen out from on top of your bed when you sleep, maybe you'll burn more calories at night. And there are devices that are, quote, sold to actually remove oxygen from above your bed when you sleep at night. And I would not recommend procuring one of those as a treatment for obesity. So let's go to 2006. Now we're starting to hear about this in the news, even though the Center for Medicare and Medicaid has not yet considered obesity to be a disease. You now have a few states where obesity prevalence is 1 out of 3. Colorado is holding its own. Most of the United States is at least 1 out of 4, and everybody is 1 out of 5 adults. Okay? And then this is the last data set before they changed the way they did the survey. So this is the last one that I could show you. And clearly the numbers are getting worse. Okay? So the vast majority of the Southeast and Texas has an obesity prevalence, this should be over here, of 1 out of every 3 adults. Right? Even Colorado has sort of lost its ground. What is the actual prevalence of obesity per state? Well, you could see that here if you're interested in your own home state. But generally speaking, it's going to be around 1 out of every 3 adults. If we added overweight, a BMI of 25 to 30, to this survey, can you give me a sense of what you think the prevalence of overweight would be? 85. So I've already definitely got my... No, it's not that bad. It's 65%. Okay, it's 2/3. 2 out of every 3 adults is either overweight or obese. There is a variance that is seen. This is a JAMA article from last year. Non-Hispanic blacks. Prevalence, this is prevalence data of obesity. It's 50%. Mexican Americans, it's 40%. All Hispanics, 39%. Non-Hispanic whites, it's 34%. In children, it's about 17% is the obesity prevalence, roughly speaking. Has it sort of settled off? Well, a little bit, depending on the data set you look at. It looks like there may be, particularly in children, where there's been a very aggressive, I don't know how successful, public health campaign, there has been some sort of stabilization of the data. And in adults, too, there may be some stabilization of the data. Now, I'm going to try and convince you that that's really still not okay. It's not actually the obesity itself that is the problem. It's the comorbidities that come along with obesity. And these are them. Obesity affects just about, and that doesn't, I'm not saying that overweight and obesity are not a disease in and of itself. It is a disease. The comorbidities of that particular disease are very common and so severe, and that's what's going to create a very big drain on our sort of healthcare system. So there's some neurologic diseases, idiopathic intracranial hypertension. There's psychosocial disorders that occur with obesity. Pulmonary obstructive sleep apnea is one of the more common disorders that occurs with obesity. In the gastrointestinal system, gallstones are very common. Non-alcoholic fatty liver disorder means a transaminitis or an increase in the level of your liver enzymes that is not related to alcohol use and or viral hepatitis. Okay? Non-alcoholic fatty liver disease is very common in obesity. It is the #1 cause of elevations in AST and ALT, all comers for anybody that has that particular hepatic profile. Far surpasses alcohol, far surpasses viral hepatitis. There's a very specific form of glomerulosclerosis that occurs with obesity. In terms of osteoarthritis, this is a huge drain on the workforce because although having more weight helps with weight-bearing skeletal strength, it sort of bears down on some of the weight-bearing joints, and so a lot of knee pain and back pain keeps people from working. Endocrine, you're going to learn about type 2 diabetes. Learned a little bit about precocious puberty already. You'll learn more of that next month. Polycystic ovarian syndrome, the most common endocrine disorder that affects young women. It's associated with obesity, although you don't have to have obesity to have polycystic ovarian syndrome. It's a combination of oligomenorrhea along with hyperandrogenism. Cardiovascular disease, there's hypertension, dyslipidemia, and all of these problems which actually lead to an increased risk of cardiovascular disease, MI, and stroke. So many complications associated with obesity. Well, what's the risk for developing those complications? So what you see here, and this predates the actual epidemic itself, is the risk compared to a BMI of between 20 and 22, which we consider to be sort of a reference standard for normal, okay, of developing either of these 4 complications in women or men. And there's a pretty linear relationship between a higher BMI and gallstones, high blood pressure, and coronary artery disease. But I want you to focus your attention on the circles, which are type 2 diabetes. Okay, you're going to learn tomorrow that obesity and insulin resistance as a result of obesity are the overwhelming causes, although we don't fully understand why, of type 2 diabetes. So here in men, if you have a BMI of 27.5, considered to be overweight, not obese, you have about a 5-fold risk of developing type 2 diabetes. Let's look up here at women. That 5-fold risk happens at a BMI of 24.5. BMI of 24.5 is actually considered normal, on the high end of normal, or low end of overweight. The actual risk for obesity I can't show you because it actually falls off the plot. Okay? But unfortunately for women, the risk of developing type 2 diabetes starts to increase even within what we consider to be a normal body mass index by the way that we measure BMI. So why am I so concerned about obesity and type 2 diabetes? Well, here's a map showing very high concentrations or estimates of the prevalence of obesity in the United States. And here's what it would look like if you did it for diagnosed diabetes. Now, diagnosed diabetes underrepresents full diabetes because 1 out of every 3 people with diabetes doesn't know they have it yet. So, how do these two, and these high prevalence rates of diabetes right now is around 10%, 8 to 10%. Those are high prevalence data for type 2 diabetes compared to obesity, where I just said the prevalence rate's around 1 in 4, 1 in 3. Depending on what part of the state you're looking at, but how do they superimpose on each other? So it's very clear and plain to see where there is a lot of obesity, there will be a lot of type 2 diabetes. Okay? Now, the obesity epidemic happens, or is happening, over the last, say, 15 years. Type 2 diabetes comes a little later. Okay? So now in the office, I'm seeing patients who are 18, 19, 20 years old with type 2 diabetes when patients at that age category overwhelmingly had type 1 diabetes 25 or 30 years ago. And oddly enough, they have dyslipidemia and hypertension and require all sorts of medications that have been tested for adults. Statins, the main drug that we use to prevent heart disease, were almost uniformly tested in people over 40 years of age. But now we have this concern that the cardiovascular system of obese 20-year-olds actually mimics or represents the cardiovascular system of a 40 or 50-year-old. But we're not really sure how effective the medications are going to be on that. Okay? So all sorts of questions are going to be raised that your generation of physicians is going to be responsible for answering. So good luck with that. Here's BMI and mortality. Incredibly controversial. Okay? There is a bit of a J-point curve here because being underweight is associated with a higher mortality as well for reasons that may have nothing to do with actual weight. The other issue that is controversial about this relationship where higher BMI is associated with higher mortality is the fact that when was this BMI measured? Because if it was measured when somebody was obese and developed congestive heart failure and got the condition that was going to lead to their mortal event, it would be, say, over here. But by the time their congestive heart failure had sort of ravaged their body and they were cachectic and they had lost a lot of weight, their BMI may be over here. And if you measured it here when they were deceased, you're underrepresenting the actual effect of the obesity and the disease that caused what ultimately was their mortality. Same with obesity-related cancers, because when people pass away from cancer, they tend to be cachectic and not eating anymore. They lose a lot of weight, so if you measure it at the time of their mortal event, it's very different than what their BMI was at the time. This has been checked again and again and again and again. The only thing I would say is that this is really sort of this hot spot of research, and that is that although our measurements suggest a normal body weight is a BMI, or fat mass is a BMI, say, 18 to 25, the lowest mortality is pretty consistently seen around 25, 26, if not maybe even up to 27. But there's a lot of statistical arguments about where actually the nadir of this curve is. Now, I mentioned this, by the way, this is BMI plotted against mortality. BMI may not be the best measurement, right? I mean, look at me. I'm all muscle. Right? So if you measure my BMI, say I was much larger and bulkier and was actually made of all muscle, I may actually have a pretty high BMI, right? But it doesn't necessarily mean I have a high fat mass, okay? So BMI has some limitations. And where the fat is distributed in somebody also matters. Fat that is put, say, in our Cushing's patients centrally, called ventral adiposity, is associated with worse metabolic outcomes than fat that is put in the subcutaneous space, so in the periphery. So where the fat is located is important, and you don't get a sense of that from BMI. So people have looked at waist circumference and waist to hip ratio. These are very hard things to measure. Okay? Someone has a protuberant abdomen, where exactly are you measuring with your tape measure? The waist circumference, where exactly is the hip so that you have your corrective factor? But the bottom line is that if you look at, say, cardiovascular death or all-cause mortality, the relationships for BMI, waist circumference, waist to hip ratio, they're basically the same. They basically show the same. So this is our best test. It's the easiest one to do. It's the most reliable one to do, and it has very little intra-observer variability for the person who's doing the measurement. But you will see lots of people complaining about the use of BMI as a means by which to talk about prevalence data for obesity in the United States. So that's the problem, okay? That's where we are currently. Not entirely optimistic view, I give you that, but it's reality. So why is this happening? Well, we don't really know yet, but we have some thoughts. Now, this is an equation, thermodynamic energy equivalence equation, that says that the energy you take in a day, in calories, and the energy you expend with either purposeful voluntary exercise or any other type of way that you expend energy, that determines what your actual fat stores are going to be like. So should energy intake overwhelm energy expenditure, you're going to gain weight and put on calories. It's going to be basically put down and stored in your fat. If you increase your energy expenditure more than you take in, well, then you're going to burn fat and lose weight, okay? And it turns out that this has also gone through this sort of big, we favor this, we don't favor this. This is now back in fashion again, okay? And this is actually what will determine overall energy balance for somebody over a given period of time. It turns out the body tries to regulate fat mass to sort of an equilibrium state, not necessarily a set point. I'm not entirely convinced that each individual has a set point, but around some type of equilibrium where there can be some flux, a little up and down, a little up and down over time, but generally speaking, the BMI, there's an attempt to try and conserve the BMI. The problem is that I think that there are factors that allow for the BMI to be pushed in the direction of increased fat mass, and those protective factors in that direction are easily overcome, whereas a loss of fat mass is guarded against by the body very well. And I'll give you some data on that as well. So how does this system work? So there are these players, and again, this is very, a simplified version, but here we have the central nervous system, hypothalamus. There are food intake signals, both pro-food intake and negative for food intake. As the food hits the GI tract, there are signals that will suppress further food intake, sort of send a signal to the brain, you don't need to eat anymore, we have enough nutrients coming on the way. These are called meal termination signals. And then there's the fat storage depots themselves, adipose tissue. And there are signals that come from adipose tissue. This all gets sort of processed by the central nervous system via the hypothalamus, okay, and the arcuate nucleus in the hypothalamus. And this dictates whether or not you're going to kind of want to go out and seek food, feel hungry, or not seek food and maybe go out and expend some energy, okay? The brain has to influence all of these inputs. So who are these inputs and what are these players? Well, you learned about ghrelin, actually. Ghrelin plays a bigger role in meal initiation than it does in growth hormone secretion. It kind of spikes 3 times a day, sort of right before you would think breakfast, lunch, and dinner would be. Okay? When the stomach is empty, ghrelin levels start to rise. And that promotes a desire to go out and seek food or feel hungry. As soon as the stomach expands, ghrelin levels fall. And they thought this played a very big role in the success of gastric bypass surgery that sort of bypassed the ghrelin signals in the stomach. That's come under a lot of fire. So the suppression of ghrelin terminates the meal, but also from gastrointestinal physiology, you may have learned about CCK, PYY, or GLP-1. These are all signals that go out. These are endocrine hormones secreted by endocrine cells that live in the gut. Why are they endocrine? Well, because they release a hormone that goes out to another part of the body that initiates a response. Okay? And they induce satiety. Okay? So if you get high levels of GLP-1, as the food hits sort of the more distal part of the intestine, it's sending a signal to the brain, hey, we got some nutrients coming, you don't need to go out and eat anymore, you can stop. These are levels, GLP-1 and PYY, that rise after gastric bypass surgery, where this part of the gut sees food a lot earlier. But whether or not they're really the main player in how successful those surgeries are, we don't know yet. And you will also learn that this has been turned into a pharmaceutical analog, okay, for type 2 diabetes that actually promotes satiety and causes weight loss. Who are the peripheral signals of adiposity? Well, it's leptin and insulin. We're going to speak predominantly about leptin today and how leptin mediates its effects in the central nervous system. Okay? So you have to learn a little bit about how the system in the central nervous system is set up. You have these orexigenic or anabolic molecules. You can imagine that means anabolic, go out, find food, store food, okay, growth promoting. Neuropeptide Y and agouti-related peptide. They're not good guys. Then you have your anorectic or catabolic molecules. These are the molecules that actually signal, okay, we don't necessarily need to eat anymore, okay? And these are POMC, welcome back, the melanocortin receptor 4, and alpha MSH. And how does the system actually work? So I'm going to walk you through two different scenarios: a gain in fat mass and how the body perceives that in the central nervous system and works against it, and a decrease in fat mass and how the body perceives that and works against it. But this is basically how the system is set up. So here we have a hypothalamic area, the arcuate nucleus of the hypothalamus. We have leptin, we have adipose tissue. Leptin goes from the periphery and crosses into the central nervous system. It suppresses a Agouti-related peptide, which is an inhibitor of POMC interacting with MC4R. And we don't know what the nuclei are that do this effect, but it makes a change in nutrient intake and energy metabolism. Metabolism being energy expenditure. So how does this work? Okay, let's see what happens if we took somebody and put them in a GCRC and fed them, say, 5,000 calories a day, which is in excess of what the body would typically need, and we force them to gain weight for, say, 2 weeks. Well, when that happens, adipose tissue rises. Leptin is a hormone that is secreted from adipose tissue proportional to the amount of adipose tissue that there is. Very important concept. Obese people with more fat mass have higher levels of leptin. Okay? So fat mass increases, right? We force-fed somebody in excess of calories. This causes a proportional rise in leptin. Leptin will then go and turn off Agouti-related peptides blockade of POMC interacting with MC4R. So since POMC can have more of an interaction with MC4R, we get an anorectic phenotype. We decrease our energy intake and increase our energy metabolism, negative energy balance, weight loss. This is a protective effect against weight gain. Okay? Clearly, though, what's happening in the United States and now for the rest of the world, this is not something that is not overcomable. Okay? But let's see the other direction. So now we're going to put somebody on 500 calories a day. And we're going to force them to lose weight and burn fat mass. Adipose tissue will decline. Leptin levels will decline. Okay, now we're taking them off of this diet and letting them go eat what we call ad libitum. Eat as you would like. Leptin levels will decline. If leptin levels decline, a Agouti-related peptide has more of an inhibitory effect of MC4R. Okay? An Agouti-related peptide is going to promote its orexigenic desires to get somebody to go out and bring those fat stores back up. So increase nutrient intake and decrease energy metabolism. Okay? Simplified version of the way that the system works to try and conserve an equilibrium, not necessarily a set point, for fat mass. So here's BMI. Say somebody had an equilibrium of around 25. And this is the amount of calories in 24 hours that you either expend or take in. So this graph is sort of showing you is that if we were to force feed somebody and bring them to a BMI of 30, and then allow them to eat on their own, their energy expenditure would go up and their energy intake would go down. And that would be negative energy balance to push them back to their equilibrium. Something in the world is pushing this in this direction, and this feedback mechanism is being overwhelmed. There's many other feedback mechanisms. This is just one example. Now, on the other hand, let's say that someone purposefully wants to lose weight. They don't like the fact that their BMI is 25. They get their BMI down to 22. Okay? And what do they tell you? I'm really hungry all the time. Right? Well, what's happening down here? Energy intake is going up. Leptin levels have fallen. Energy expenditure is going down. I'll show you some data on that. Positive energy balance back here. This is not so easy to overcome. This has probably been so preserved evolutionarily, or evolution-based, whatever the correct grammatical term is, based on the lack of food availability. Right? In case you haven't noticed, we don't live where there's a lack of food availability. And in case you haven't noticed, the food that is available, some would argue, is questionably food at best. Something in the environment is causing a disruption in, for example, leptin's ability to do its job in the central nervous system. And we have labeled this leptin resistance. We don't know what it is. You hear people talk about it's trans fats, it's high fructose corn syrup, it's diet soda, it's skim milk. We don't know, and it is really hard to figure out. Here's what the system looked like about 10 years ago, a little bit more complex. You know all these players now, okay? So you shouldn't have too much trouble sort of deciphering what's going on here. And I'm going to leave it to you, but this is about as simple as I can show it without it getting so arrow-based that it actually looks, you know, dissociative to your eyes. So what is this leptin resistance phenomenon? Well, what we have here, this is in mice, okay? We have two diets being fed to the same mouse. And I didn't do these studies. I just want to show you them. These studies, I'm a big animal rights person, in case you haven't figured that out, because I haven't told any stories about why you would have figured that out. But I am a big animal rights person. So what I am about to say, I just want you to be aware, I didn't do. But they take a drill, and they drill a hole into the skull of this animal, and they drop a cannula, a tube, into the arcuate nucleus, the central nervous system, so that they can bathe the hypothalamus with hormones and see what the response is for energy expenditure and energy intake. Okay? They fed these mice two different diets. This is a low-fat diet here, and this is a high-fat diet here. Okay? Now, watch what happens. 24-hour food take. Low-fat diet with just saline, that's your basal level. Low-fat diet with saline, you know, typical weight kind of goes up or down in a regular day. They then stopped the saline infusion and infused leptin directly into the brain. That should decrease energy intake, promote energy expenditure, and it does. Decreased energy intake, weight loss, negative energy balance. Leptin is doing what it's supposed to do on a low-fat diet. Here we have a high-fat diet. Saline. Here's the response when they drip in the leptin. There is no response. There is no decrease in food intake, and there is no significant weight change. This is a model of leptin resistance. Is high-fat diet the cause? Well, we're not really sure. It was a mix of different types of fats. Some polyunsaturated, some monounsaturated, some saturated fats. It's also an animal model. But it is the start of how we're going to try and figure out what are these mechanisms that are pushing the equilibrium point so far to the right and making it so difficult to move back. So let's talk about the other side of the equation, energy expenditure. If you read the New York Times yesterday, I tried just to count the number of articles that reference something about either exercise, food intake, or weight. I think there were 5 that were posted yesterday alone. One of them had to do with breakfast, right? Skip breakfast, you're going to be hungry for the rest of the day. Apparently bunk, okay? Skipping breakfast has nothing to do with weight regulation. The other was a very interesting question. If I want to lose weight, should I cycle or should I run? Okay? These are the kind of questions people are asking. Turns out the answer to that is, what do you want to injure first? Your knees, you should run. If you want to injure sort of your whole system, I guess, later on in life, then cycling is apparently a very good thing to do. But it raises this concept of energy expenditure, and it's important. I'm going to come back to it in a second, because the type of exercise you do and how good your body is at preserving your energy when you exercise plays a critical role in how you can change your overall fat mass. So what do I mean by that? Most of your metabolic rate, resting metabolic rate, the moment that you wake up, before there's been any perturbations of the day, before your alarm clock goes off, that's actually decided by your lean body mass, okay? And that's depicted here. Very well proven, lean body mass determines resting metabolic rate. But the total daily energy expenditure in a day takes resting metabolic rate and adds to it these two things. One, dietary thermogenesis. the amount of energy it takes for you to metabolize, well, masticate, and then digest, and then absorb nutrients. You may have heard that celery is a wonder food because it takes so many calories just to chew that stringy stuff that you're going to lose weight by eating it because you expend more calories than you do actually absorbing it. Say it with me. Bunk. Okay? This is an unchangeable process. You may not alter. There's nothing that we know that alters the actual dietary thermogenesis. It's fixed. And there are no superfoods that allow you to lose weight by exclusively eating them because you burn more calories. The thermic effect of exercise, on the other hand, is a fancy term for saying how much voluntary exercise do you do in a day or how much non-voluntary exercise you do in a day. And that you can change. Right? So you all think I'm walking around because I can't sit still and I have some type of, thyroid condition, but it's not actually true. I'm increasing what's called non-exercise activity thermogenesis, or NEAT, which is a way for anybody who right now is watching their foot twitch, right, or their elbow shake, or their hands not be able to sit still, that you burn calories. And there's a science actually devoted to how much calories can be burned by these kind of activities. If you stand and watch television, you're burning more calories than if you sit and watch TV or lie down and watch TV. Sitting and watching TV is as calorically productive as sleeping, by the way. Just in case standing, you'll burn twice as many calories, but it's not really exercise. But you are burning more calories doing it. So there's voluntary and involuntary physical activity that you do in a day. Now, I mentioned that it's really important because how your body responds to changes in weight in terms of your energy expenditure can play a role in fat mass equilibrium. So let's take somebody and have them at their initial weight. We'll bring them into the GCRC, and we will force feed them to expand their weight by 10%. Well, then, when they start to exercise at this higher body mass, because we can predict, based on body mass, their metabolic rate, we have a sense of what we should find in terms of their energy expenditure. And it turns out that when you gain weight, there is this protective mechanism that allows your observed energy expenditure to actually be higher than what we would predict it to be, which is great. That means you're not exercising efficiently, so you're burning more calories when you're doing the exercise. Fantastic. So then we bring somebody back to their initial weight. Now we put them on a hypocaloric diet, and we force them to lose weight. Okay? Unfortunately, the opposite also occurs. So what you're seeing now at 10 and 20% weight loss is that the body is becoming quite efficient at the exercise you are doing. In other words, for the same amount of exercise, you're burning less calories. If you burn less calories for the same amount of exercise and you are in a fixed caloric intake, you're going to be in positive energy balance. And one of my colleagues used to come up here and tell a story about how, before this was realized, most people thought, well, patients were really lying about what it was that their food intake was. But it turns out they weren't. If you stay on a fixed caloric intake and you are successful at losing weight, the body will work against you by becoming more energy efficient at the exercise you're doing and force you to be in positive energy balance and put weight back on. And that's the idea necessarily from this question in the Times yesterday about cycling or running and which is better for weight loss. Okay, so those are some of the mechanisms moving the equilibrium point one direction or the other. I'm just going to run out of time, so for this one, I'll just take questions at the end. So, how do genes and the environment play sort of together? Well, there are not a lot of monogenic syndromes that are associated with obesity. They're very rare, actually. They may explain only single-digit percentage of the obesity that we see. Most obesity is sort of polygenic. You have a variety of susceptibility genes, and someone is placed in an environment that could be toxic for whatever reason. There's high levels of food intake and sort of noxious food. There's low levels of exercise. So this environmental component on top of a polygenic predisposition to obesity can lead to obesity. And that's something that Dr. Crandall's going to talk about when she talks about Pima Indians and type 2 diabetes. But these monogenic syndromes are actually quite important because they are what is helping us elucidate the pathways that we know about and that I showed you about regarding obesity. So for the monogenic syndromes, you can see these are all basically the same players that I had mentioned before. There's leptin, the leptin receptor, POMC, melanocortin-4 receptor. But these are very, very, very rare. They don't explain a lot of the obesity epidemic. Now, this is a young child who does not make leptin. Remember, lack of leptin means he's going to be promoting the ingestion of food and decreased energy expenditure. Okay, so this is a 3-year-old, and he weighs about 90 pounds. However, recombinant human leptin was discovered and thought to be this is going to save us all from developing obesity. Well, it works very well in this child who actually doesn't make any leptin, right? So you could see 3 years later, you know, pretty normal body habitus. If this was a leptin receptor defect, this would not work, right? You can't give leptin, you can't overcome a receptor defect. And as I mentioned before, since monogenic syndromes don't explain a lot of the obesity epidemic, and leptin is secreted proportional to fat mass, most people with, well, people with higher fat mass have higher levels of leptin. It's some type of leptin resistance. You're going to learn about insulin resistance a lot tomorrow. Some type of leptin resistance that's playing a role. May not be the only player, but is playing a role. So leptin injections were tried in lots of unsuccessful obesity trials. There may be a role for weight maintenance and leptin injections, but that's sort of being studied right now. So how much of the genetics play a role versus how much of the environment? It's probably 2/3 genetics and 1/3 environment. You could see here this is taking adopted children and classifying them in 4 different weight classes. Okay? As you go from the group of children who are thin to the group of children who are obese, there's a nice correlation between biological mom and biological dad. That relationship does not exist amongst the adopted parents. Okay? So there's more of a genetic component than there is of an environmental component, but that is not to say that the environmental component is not significant or not important. And that's just sort of diagrammed here by a couple of different studies. All right, so now we're going to sort of walk out a little bit and go over some treatment paradigms for obesity. You know, I mentioned sort of in passing that the Center for Medicare and Medicaid only classified obesity as a disease a couple years ago. And what that basically means is if the Center for Medicare and Medicaid doesn't classify something as a disease, as a physician, you can't get paid for trying to treat it. Not to say that that means you don't try to treat it. It just means that if you were to, say, try and tell the insurance company, well, I treated this patient with all of these wonderful modalities and I spent all of this time with them because they have obesity, the insurance company would say obesity is not a disease. So we are not paying you for that service. That's changed now, so that's good, right? We're moving in the right direction. Don't be so negative like me. So what can you do? Well, hypocaloric diets, behavioral modification, intense exercise regimens. Well, those are 3 nice things because they play on both sides of the equation. Combinations of 1, 2, 3. You can do pharmacotherapy. Remember I said BMI cutoffs are a little arbitrary except when it comes to treatment, so this is where the treatment part comes in. If you have a BMI greater than 27 and any obesity-related comorbidity, type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, that is a reason that you can use pharmacotherapy if you can find a drug that's actually effective. You can do combinations of 1, 2, 3, and 5, or weight reduction surgery. And there's a National Institute of Health guideline for who can and who should not get weight reduction surgery. It is a moving target now. I'll tell you that right off the bat. It used to be a BMI of greater than 35 and a comorbidity. There are a lot of studies being done on BMIs greater than 30 and a comorbidity, particularly diabetes, because the cure rate with surgery for curing type 2 diabetes is quite high, okay? Or if there's no comorbidities, a BMI greater than 40. But again, these are somewhat arbitrary, and there's different groups who are studying different values for interventions. So what is a hypocaloric diet? Well, it turns out that if you take a pound of fat and you put it in what's called a bomb calorimeter and you blow it up, it actually has 3,500 calories associated with it, which is great because as an endocrinologist, I'm not very good at math, but I can take 7 and divide it into 3,500. And that means if I wanted somebody to lose a pound of fat per week, I can recommend that they try and cut their diet down by 500 calories. By the way, how many calories is the pretzel that you can get at Yankee Stadium? That's right, it's 680. How about the large tub of popcorn at Yankee Stadium? Not that I don't like Yankee Stadium, I love Yankee Stadium. Popcorn, 2,400 calories. Hot dog, 250. Right? Hot dog, healthy choice. Look how few calories it has. Anyway, a deficit of 500 calories a day would lead to a loss of about a pound per week, provided those mechanisms I talked to you about before do not sort of rear their ugly heads and sort of work against you. But this is the general principle, right? This is about 2 cans of soda, okay? However, it's really important to know what a patient's energy expenditure is for that day. And we don't have great tools of figuring that out. We have some equations we could use that can give us some sense. The reason why I say this is so important is if you say to somebody, well, just have 1,800 calories a day, and their energy expenditure is 3,200 calories in a day, you're asking them to cut, basically, their caloric intake by 50%. And that's really hard to do. Okay, so that person at 3,200 calories, you're kind of aiming for 2,700 calories, something a little easier, a little bit more sustainable. On the other hand, if you recommend 1,800 calories to somebody who is exerting 2,000 calories a day, you're going to be unsuccessful because you're not reaching sort of the thresholds you need for the deficit. Now, exercise comes in, a lot of people, you know, they say, okay, I'm going to try a lifestyle intervention, I'm going to cut my food intake, and I'm going to go out and exercise. Some people just go out and exercise. It turns out that exercise is not so effective at weight loss. It's quite effective at weight maintenance. So we kind of bring exercise in after the hypocaloric diet has allowed for weight reduction. Okay. Now this slide is from 20 years ago and has not changed. And this is probably not something you're going to want to talk to your family about, okay, when they start asking you questions at the dinner table in the next couple of weeks or through the upcoming holiday season. What I am showing you is this is the 0 level, okay, for all comers who enroll in a trial that involves a hypocaloric diet or behavioral modification or the combination of the two of them as a means by which to lose weight, and how successful they are at 5 years. Okay? So this is a very low-calorie diet, this is behavioral modification, and this is combined. Here's their success rate at 5 years. It's about 0%. Now, if you measure things at 6 months, and this is with almost every form of weight reduction there is, be it surgical, pharmacological, or these, you will see really nice results. Okay? And then all of a sudden these protective mechanisms seem to kick in. And this sort of curve that I'm showing you here is with all forms of weight reduction. Diets alone, as you know, you don't need this table. I mean, you've heard it before. It's very hard to lose weight. It's very hard to sustain that weight loss. And that's basically what you're seeing here. And these are basically controlled trials. You know, heavy interventions, not just a pamphlet that says go out and, you know, eat healthy, okay? It's just very hard to do. I show this slide because you're actually seeing here's 0, change in weight. This is a New England Journal study from a few years ago. This is all different macronutrient compositions and how successful they are. You know, you can have the Atkins thing or the Ornish thing, and you can change your fat to your protein and your carb ratios. This was a very well done study, 2 years in duration. And it has the same 6-month nadir and then sort of a rise, not necessarily back to baseline, but we're only 2 years out here, and baseline usually comes back at around 5 years. But there's not one time point where macronutrient composition matters in terms of weight loss. Could it play a role in things like insulin resistance and dyslipidemia? Maybe. Okay, the jury's not out. But this kind of closed the book that it's the type of nutrients that you intake that will have an effect on your ability to lose weight. Okay, so for all of the non-believers in the energy equilibrium equation, this study is somewhat hard to refute. Okay, so that's hypocaloric diets, behavioral modification, intensive exercise. Here's pharmacotherapy. This was a drug called sibutramine, moderately effective, maybe 4 kilograms of weight loss. By the way, let me just show you this. This is the amount of weight in kilograms that was lost on average by these groups at 2 years. If we walk over here, it's about 3 kilos. That's around 7 pounds, 8 pounds, something like that. Okay, so 2 years, intensive randomized control trial, keeping with the diets that they're recommending, life coaches, all of that stuff, 7 pounds of weight loss. Okay, when you have a conversation with, and I'm not saying that this weight loss is not insignificant, because it doesn't take so much weight. It's only about maybe 5 to 7% weight loss. Could have a marked reduction in your risk of developing type 2 diabetes. I'm not at all saying it's not insignificant. But you have to be honest with somebody that this is the amount of weight loss you could expect to lose. Don't have somebody who may weigh, say, 300, 350 pounds and say, well, we're going to go on this modification and we're going to do this diet and you're going to lose 50 to 100 pounds. There's not evidence to support that. You may lose about 5 to 10% of your starting weight, which may have very good cardiovascular beneficial protective effects, but cosmetically may be trivial to the patient. Turns out we don't use sibutramine anymore because when it was studied in a nice randomized clinical trial, it increased the risk of cardiovascular disease. So you're trying to prevent obesity-related complications, and it actually induced an increased risk in obesity-related or one of the more feared obesity-related complications, so we don't use it. Orlistat is a sort of fat inhibitor in the gastrointestinal system, very well studied. Also, after 1, 2, or 3-year trials, there's maybe 3 to 4 kilos of weight loss with this drug if you stay on it. It's available over the counter in 50% prescription, or 50% of the prescription strength is available over the counter as something called Ally. This is a new medication that was FDA approved, lorcaserin. It works through serotonin pathways. Okay? What you're seeing here is body weight during year 1. Here's placebo, maybe a 2 kilogram weight loss. With the drug itself, there's about a 5 kilogram weight loss. But focus your energy on this one. This is what happens over 2 years. Now this was really exciting because now we have a drug at a year that hasn't started that up creep, sort of back to baseline. But unfortunately, when they extended the trial, they noticed 2 things. Patients who kept taking it, if they were still taking it, started to inch closer and closer and closer to placebo and gained a little bit of weight. They didn't go back to their baseline, but they gained weight. If you didn't take the drug for the 2nd year, it was as if you never took the drug to begin with. Okay? So this is a table of available, or were at once thought to be available or promising drugs for weight loss. They were all either pulled off the market for side effects or they never sort of passed muster. And so this is the only one really that's left. Phentermine is used. Phentermine has been combined with drugs like Topamax or bupropion, which are drugs for different indications but may cause some significant weight loss. So you could take something like phentermine, which is a bit of a stimulant, add it to something else, and then get that passed by the FDA as a means by which to combat obesity. But there is no wonder drug that we have yet. Okay? But there may be a sort of, quote, wonder procedure, and that is bariatric surgery or weight reduction surgery. Now, weight reduction surgery comes in 2 flavors. There's a purely restrictive laparoscopic adjustable gastric band. They put this ring around the top part of the stomach and a basically cannula here that goes to a port that you could fill with more saline. So as somebody gets more and more hungry, you could sort of tighten up this band and reduce their desire to eat or their ability to eat because you're reducing the size of a stomach that's available for food. There's no changing of the architecture, okay? And this is reversible. But once this comes out, weight gain usually ensues. Okay, this is effective, but not quite as effective as this procedure. This procedure here is a Roux-en-Y gastric bypass. You do restrict stomach availability by basically cutting off the rest of the stomach except for this very tiny pouch. You then bring up a piece of ileum or jejunum, depends on where they actually want the malabsorption part to begin, up to the proximal part of the stomach. So food goes down this way. Digestive juices come in this way, and then they meet further down in the gastrointestinal tract. And remember I said that there are these endocrine cells in the small intestine that secrete hormones like PYY and GLP-1, and these are meal termination signals when they make their way up to the central nervous system. There is a thought that not only is this restrictive and a bit malabsorptive because you don't get the digestive juices and the food together until much further down, okay, and you're bypassing the entire duodenum, but maybe these endocrine cells are sending out their signals early, and that promotes satiety, which promotes decreased energy intake, which promotes weight loss. So how good are these? Well, this is a pamphlet given to a patient. That's the control arm. It's not really a controlled study when that's your control arm, but that's basically what they did. This is not really done anymore, VBG, don't worry about that. This is banding. The data on banding is a little better than this because this is a non-adjustable and adjustable band versus what we do now, which is a pure adjustable band. And this is gastric bypass. Now notice, you see the same sort of curve, right? About 6 months to a year, you get your nadir, and then there's weight regain. You know, when famous people undergo their weight reduction surgery and they start gaining weight back, which we completely expect them to do, everybody basically pounces and says, see, it's not successful, it's not successful. That's not true. We expect this. We counsel patients on this. We make them aware that at some point they're going to start gaining weight back. But notice, they don't come anywhere near to where their initial weights were, and that's the big difference between weight reduction surgery and everything else that we have available right now. So gastric bypass can be associated with losing 30% of your initial body weight. This is percentage. This is not kilograms, as you saw for the drug studies. What else happens with weight reduction surgery? Well, this is improvement of these obesity-related comorbidities, diabetes, hypertension, dyslipidemia. These numbers are staggeringly better than what we could do with medicine. Okay? How about resolution, though? A cure, a surgical cure for type 2 diabetes. Turns out it was thought of in the 90s, actually, that surgery may be able to cure type 2 diabetes. And the more we learn about it, the more we do see that although we have no idea of what the mechanism is, there certainly is something going on with weight reduction surgery, in particular the bypass procedures, where patients are basically cured of their diabetes. And that cure is within days, if not weeks, much earlier than we actually see the weight loss. Meaning something is going on in the gut-brain signaling pathway from the surgery that is inducing this resolution of their diabetes. And I think that's all that I have to say on the topic. And that's it. So type 1 diabetes starts in about 10 minutes. I'll hang up here for questions. And that's really it. Enjoy your break.